We're excited to now bring you a panel of speakers to help us learn about two evidence-based approaches that can be implemented in primary care to improve clinical outcomes, measurement-based care and collaborative care, and to learn how health plans and public payers can support these approaches. We're joined by Henry Harbin, Special Advisor to the Kennedy Forum, John Fortney, Director of the Division of Population Health in the Department of Psychiatry at the University of Washington, and Dr. Glenda Wren, Associate Professor in the Department of Psychiatry and Behavioral Sciences at Morehouse School of Medicine. Turn it over now to Henry.
Thank you, Catherine. This is Henry Harbin. As Catherine said, we're going to focus on two specific areas today. One, actually the first one, is going to be on best practices for integrating behavioral health care into primary care and vice versa. That's going to be by John Fortney, and the second on measurement-based care by Glenda Wren. In this area, we're going to focus on really probably the most evidence-based practice on how to integrate the general medical system in mental health and substance abuse, a particular evidence-based intervention called collaborative care to improve mental health services and substance abuse services in primary care. The second area, what we're calling measurement-based care, is a focus on trying to improve accountability and transparency for those providers when they treat people with mental health and substance abuse disorders. And the focus here is really on trying to improve the accountability and transparency by both primary care physicians if they treat a person with these disorders, but also the whole specialty behavioral system. Specifically, we're advocating here for the use of standardized quantifiable instruments when you track and treat a person with these disorders, just like an internist would do when they are measuring blood pressure regularly when they're treating hypertension, or hemoglobin A1Cs when they're treating diabetes. Both of these priority areas have been a policy and advocacy of the Kennedy Forum. All three of us have been consultants to the Kennedy Forum over the last year or so to how to help the Kennedy Forum develop key policy areas. Patrick Kennedy created the Kennedy Forum about 2 years ago as a policy think tank and advocacy group to try to identify important policy areas that could transform the both access and the quality and effectiveness of care for people with these disorders. And as you heard from Sarah and Chris, if you look at the public health metrics, both on suicide rates, disability rates, opiate deaths, the system is going in the wrong way. We're seeing a rapid deterioration of these public health metrics for people with these problems, and these are some of the solutions I think can help turn that around. I'd like to say we were really pleased to see the announcement by CMS just in the past 2 weeks to announce a payment code, the creation of a payment code for payment for collaborative care and primary care, which John will talk more detail about. But this opens up, this is for Medicare Part B. It starts January 1, 2017. It creates a code that would be paid for or billed by primary care practices and would provide for the provision of hiring a behavioral health care manager that would work within the practice and also a consulting psychiatrist. This intervention has over 80 randomized controlled trials. I think this is particularly important, this creation of payment in Medicare for all of the private insurers on the phone, if there are any Medicaid insurers, because this now creates a payment code for you all to be able to offer this evidence-based intervention. One of the reasons this is important is the majority of patients with mental health and substance abuse conditions are not treated in the specialty behavioral system. They're treated and they get all of their care in the primary care system. And we know that unfortunately many of these outcomes are quite poor without these additional behavioral health resources that are applied within the practice. So I'm going to turn this over now to John to give us more detail about collaborative care, and then Glenda to come there on what is important and how do we move forward on measurement-based care. John?
Thank you, Henry. Thank you, Catherine, and I'd like to thank the Kennedy Forum for pulling this panel together. I'm going to echo some of the information that Chris had talked about and start off by saying that inadequately treated mental health disorders account for 27% of all disability in the United States. So that's a very large percentage. As you can see in this table, it shows the cost of the mental health disorders to payers. So you can see that 14% of commercial plan enrollees have a behavioral health diagnosis, a little lower in Medicare, a little higher in Medicaid, about 15%. And the next two columns show the per member per month payments for those with and without a diagnosis, a behavioral health diagnosis. And you can see that those with 2.5 to 3.5 higher costs than those without. So for all insurers, it's 273% higher. And these are not due to the higher cost of treating behavioral health disorders. In fact, only a small portion of the cost associated with the delivery of mental health care. These are due to having to treat more physical health conditions for this population, the poor outcomes for the physical health treatment in this population, the greater number of ER visits, and hospitalizations. In fact, we don't really reach many of the individuals with mental health disorders with our services. So this slide comes from the National Comorbidity Study. The big blue circle is every states with a mental health disorder. You can only see about a third or 36% get any formal treatment over the course of a year. Only 22% get any specialty mental health care, and only 12% psychiatry. So we need to figure out how to reach a greater number of these people. And even if we were to improve their access through lower costs or closer services, the U.S. does not have the capacity to treat all these patients in especially mental health. First, to estimate that 96% of U.S. counties have a shortage of psychiatrists, with 70% of the need going unmet in these counties. So it's just not possible to refer our way out of this problem from referring from primary care to specialty care. So how do we reach these patients? And the most promising approach is to improve the management of mental health disorders in the primary care setting. This improves access for patients because it's provided in their nearby primary care clinic where they can get more timely appointments. It's less stigmatizing, and there are lower out-of-pocket costs for patients in the primary care setting. Equally as important, not only does it increase engagement for patients, but it also increases the capacity of specialty mental health providers, because instead of taking over the treatment, they provide consultation and collaborate in time-limited treatments. So it increases access to patients and increases the capacity of the mental health providers. Now, there are lots of integrated care models out there to choose from. Most of the models are not evidence-based, meaning they have not been subject to rigorous evaluations. And some of those that have been evaluated in a rigorous way have been shown not to work. So a number of things have been found to not be better than usual care, including trying to educate primary care providers about how to treat mental health disorders. Likewise, provider profiling does not help. Screening for depression does not help unless there are adequate systems in place to ensure accurate diagnosis and treatment. And the two most commonly used approaches to integrated care are also known not to work. So simply co-locating a mental health provider in a primary care clinic without systematic tracking of outcomes and delivery of evidence-based treatments does not work. And nor does disease management, whereby the health plan uses care managers to work with patients, but they don't collaborate closely with the primary care provider. So those approaches are known not to work. Collaborative care is one of the evidence-based integrated care practices. It's a specific type of integrated care model that operationalizes the principles of the chronic care model to improve access to evidence-based mental health treatments for primary care patients. It's team-based. It's led by the primary care provider, who's supported by a care manager, and who gets consultation from a psychiatrist. The psychiatrist will provide treatment recommendations for those patients who aren't improving as expected. It's typically the psychiatrist does not have encounters with patients, but rather the care manager reaches out to the patient, assesses their symptoms and treatment adherence, communicates that to the psychiatrist when there's a problem, and then the psychiatrist makes a recommendation about how to change the treatment plan to the primary care provider. It's population-based in that it uses a registry to monitor treatment adherence and dropout. It is measurement-based, meaning they monitor a patient-reported outcomes over time to assess treatment response and to determine when changes to the treatment plan need to be made. Glenda is going to be talking about that, more about that in a minute. It's very patient-centered, so the care manager does proactive outreach to engage patients, activate them, promote self-management and treatment adherence, and coordinate their services. It is evidence-based, so it's demonstrated cost-effectiveness in a diverse practice settings and patient populations, and it's also practice-tested, so there's been sustained adoption in hundreds of clinics across the country. I just want to emphasize the importance of using a registry. This helps the care managers manage their caseload so they can identify which patients aren't engaged in care, which are falling through the cracks, and to evaluate outcomes over time and prioritize patients for discussion during the psychiatric case review and consultation. Registries can be as simple as spreadsheets, but a fully functioning registry includes self-scoring rating scales, screeners, and decision support. Electronic health record vendors are starting to make some progress to build in registry functioning into their products, but there's a long way to go. There are also some HIPAA-compliant web-based registries that are available, like the one offered by our AIMS Center. So as Henry discussed earlier, there was a Cochrane review of the collaborative care model. There were 79 randomized controlled trials that had more than 24,000 patients enrolled in them. And compared to usual care, and usual care is usually screening for depression or anxiety and then referring the patient to especially mental health. Compared to usual care, there are higher response and remission rates, where response is a 50% reduction in symptoms and remission is symptom-free. And they're big, the clinical improvement substantial. So compared to usual care, collaborative care generates an 18% median absolute increase in response rates and a 17% median increase in remission rates. So there's a big improvements. It's also associated consistently with improvements in quality of life, patient satisfaction, and lower costs over the long run. These results are consistent across diverse populations. It's been shown to be effective in all stages of life. It's effective for minorities, and it's effective across a range of diagnoses, including depression, anxiety, and substance abuse, where it focuses on medication-assisted treatment that Sarah was talking about. I can imagine that some of you are thinking that most primary care practices are not big enough to support a full-time care manager and a psychiatrist, and it's not possible to implement. But actually, this is not the case. The collaborative care model is effective even when the primary care provider, care manager, and psychiatrist are not physically co-located with one another. With today's health information technology, all these providers can collaborate with one another remotely. And as you can see in this figure, with the patient in the middle, they still meet with their primary care provider face-to-face during traditional primary care appointments. In between those appointments, the care manager will make telephone calls, outreach calls to the patient. When the patient's not doing well, the care manager will use the registry and telephone to communicate with the psychiatric consultant, who will then come up with a revised treatment plan. And this revised treatment plan is communicated to the primary care provider through usually a progress note in the electronic health records. A 2013 HRQ report concludes that collaborative care improves outcomes regardless of whether the collaborating providers are co-located. And I personally conducted 3 successful RCTs in small rural primary care practices where the care manager, primary care provider, and psychiatrist were not co-located with one another. Collaborative care is practice tested outside the context of research. So there have been numerous implementation trials and demonstration projects that show that it's feasible to implement and effective under real-world conditions. Just a few examples here are Compass, which was done in 7 states with Medicare and Medicaid plans that enrolled 4,000 patients. Another was Diamond, which was conducted in Minnesota with multiple commercial insurers. They used a bundled case rate to pay for collaborative care, and there were 12,000 patients in that demonstration. Here in Washington State, the Mental Health Integration Program has been operating since 2008. It also uses a bundled case rate to pay for performance, and 55,000 federally qualified health center patients have gone through that program. And the VA actually has the biggest integrated program in the U.S. that served over 1 million veterans. And this model combines both the collaborative care model and the behavioral health consultant model, which is another popular model of integrated care. And just to highlight that, we're recommending that the collaborative care model be a key element of a stepped care approach to treating mental health disorders. So starting from the bottom of this stepped care pyramid, many, if not most, mental health disorders can be handled by the PCP without any help. So that's step 1. Another portion require a curbside consultation with a consulting psychiatrist. Step 2, and for many patients, step 3, a warm handoff to a co-located mental health specialist for 4 to 6 sessions of counseling is very effective. That's the behavioral health consultant model. However, for a sizable portion, patients need more than that, and they will need more intensive collaborative care to achieve response before being discharged back to the primary care provider. That's collaborative care in step 4. And then some patients, of course, will need to be referred to the specialty mental health care system. So if you're interested in deploying the collaborative care model, you need more information. There's a number of resources that are available. As Henry mentioned, the Kennedy Forum recently published an issue brief that details collaborative care and summarizes the key issues, and it provides guidance and recommendations for implementing collaborative care for purchasers, provider organizations, clinicians, patients, and family members. And that is available at that link at the bottom. Our group has recently published a book about implementing collaborative care. It's a very practical how-to book. One of the co-authors is Wayne Caton, who conducted the very first randomized trial of collaborative care here at the University of Washington. Recently passed away. It includes lots of case studies and other practical information about how to develop effective integrated care teams. And the Advancing Integrated Mental Health Solutions, or the AIM Center, also provides hands-on support for implementing collaborative care. Our website offers a lot of free tools and webinars, and you can work with us to get more hands-on training in implementation. It's usually a 3-step process where you go to the website and do some self-learning, and then we come to your site to do an on-site training that's very experiential and active learning. It takes 1 to 2 days. And then we provide post-implementation technical supports and coaching. We provide webinars as well as case study calls for the care managers and support for the consulting psychiatrists. Our AIM Center is also working with the APA to train thousands of psychiatrists in consultation and case review under the context of the collaborative care model. A couple of past 12 to 18 months, there have been a couple of policy changes that strongly incentivize the implementation of collaborative care. The USPS now only recommends depression screening if a clinic has adequate systems in place to ensure accurate diagnosis and treatment. That's because screening alone is not effective. In 2016, the Medicare consensus core set for accountable care organizations and patient-centered medical homes added depression, remission, and response as outcome performance measures. And as I reported before, these two outcomes can be substantially improved by collaborative care by 17 and 18% respectively, absolute percent. And then in 2017, NCQA HEDIS depression metrics will include monitoring patients' outcomes with depression using a PHQ-9 or PHQ-A. Brenda will talk more about that measurement-based care approach, which is critical, but it will also add metrics on depression, remission, and response. And then finally, there have been, just in the last couple of months, major progress on reimbursement for collaborative care. The AMA CPT board just approved CPT codes for collaborative care. As Henry mentioned, CMS has proposed new G codes for the Medicare fee schedule for 2017. This is likely to be adopted by private insurers as well. New York and Washington State Medicaid have collaborative care programs, which is a monthly case rate for eligible beneficiaries. It bundles the payment for the care management and psychiatric case review with pay for performance withholds. And many accountable care organizations are being held for mental health outcomes as well. So for example, here in Seattle, Boeing's contract with the University of Washington ACO includes benchmarks for depression response and remission rates, where our UW is at risk if PHQ-9 scores are not collected or our patients are not improving according to benchmarks. And so the NCQA HEDIS depression metrics are kind of driving this value-based purchasing. So I think I'll stop there. Thank you very much.